Okay, three, two, one. Hello, and welcome to another episode of the Elevation Association Experience. We are your hosts, Dr. Dan Nelson and Dr. Jared Hill. We've got a great show lined up today. Really excited to be talking about this in our series, our KPI series. Uh, we were just kind of laughing because I'm trying to spruce up the joint here a little bit with our blank brick background. And so I've like put out some flowers. Jared was teasing me because we've got.
They're beautiful, dude.
Should I just hold them the whole time? Would that be good?
Nice,
Just
beautiful roses. I'm not even sure where you got those flowers. Aren't those flowers that one of our assistants got from her boyfriend?
that doesn't matter.
Okay,
No, they're for me. They're
they're
for
for
me.
you.
They're
Well,
yeah. I have many admirers. Notice that there's three of them. Probably three
you
admirers
you
sent them.
deserve it. You deserve it, dude.
Yeah. Well, I mean, they're red. It's probably because I have so much passion.
Yeah, yeah,
Yeah,
yeah.
but in the end, we left him out. So, and if anyone's listening to this, you can't see him anyway. So it's all for naught.
Or not.
Well, Jared, let's roll this out. This is so we were just barely talking to Ryan about this particular KPI, right? Case acceptance rate. And this is one that I think is A, either ignored or B, completely overestimated, right?
Yeah, it's not only overestimated, but people don't know how to track it. They don't know how to find it. They don't know how to see what it really is. And so this is a classic example of how KPI is based off of an emotional feeling. I feel like we accept everything. I feel like we have a really high acceptance rate.
What would you think that the average office uh assumes that their acceptance rate is?
Oh, way too high. First of all, I don't know that anybody has ever, I don't know that I shouldn't say this. I think very few people step back and say, my case acceptance is 30, 40, 50, 70, 80%, whatever it is. Most people are like, oh yeah, I think we treatment plan and we present and we schedule almost everything. So I would probably say, if I had to guess, I would say the average dentist probably thinks their case acceptance is, I don't know, 75, 80% or so.
That'd be my guess too. Just and a lot of it is like you're saying, they don't know how to track it. So it's based on feel, right? Like, oh yeah, like and I think that I think that this is a point of, I don't know, I don't want to say failure, but a weak point in most offices, right? Because there's an overconfidence in the ability, an overconfidence in the success rate that it's going on here. Um, yeah, so let's get into this. Let's talk about let's dive into this silent leak in most practices. So poor case acceptance is what we're talking about, and let's talk about how to fix it. Um,
Yeah, this is unlocking hidden revenue in your practice.
totally,
Like you said, it's
totally.
a silent leak. Like you may be doing all you can as the provider to diagnose. Maybe you're a great diagnoser. Maybe you have a great conversation with your hygienist. Maybe he or she sets you up perfectly for case acceptance. But unless you know how to track it, unless you know how to see if it's actually being scheduled, then it could be, like you said, it could be this silent leak of revenue in your practice that could easily be fixed. And I'm excited to dive into that today.
So I kind of want to start out with an example that I think we've all experienced or all been part of, right? And it's you go, I don't know, I'm a car guy, so I'm gonna pick that. So you go to shop for a car, right? And there's been times where, or you're shopping for like just yesterday I was shopping for a new mountain bike and so I'm just looking, kind of window shopping a little bit, right? And uh, so you go in and you're whatever you're looking for, and someone comes up to help you out, right? And the guy that was helping me yesterday, so we'll just stay with the mountain bike thing. The guy that was helping me yesterday is freaking stud. He's a buddy of mine. I ride motorcycles with him. I ride mountain bikes with him. He coaches my son in mountain bikes. And so we get talking shop and we're talking about different things and you start to like nod, right? You're like, uh-huh, yeah, yeah, like whatever bike that I was looking at was like, yeah, yeah. And there's a point where you want to escape, and this is a friend of mine, right? Like I want to, I enjoy just like shooting stuff with him and just chatting. But there's a point where you're like, okay, I need to escape. And so maybe you're not ready for it. Maybe you don't have the finances in line. Maybe there's other things you want to explore. Maybe there's all these huge factors, especially when a patient comes into our office that can go into their decision-making process, right? Mine yesterday was ignorance. I didn't know what other options were out there. I just started looking 2 days ago, and that was the first shop I actually went into. And so you start nodding like, yeah, oh yeah, probably, yeah, yeah, this sounds like a good thing. I'll probably do this maybe, and that's where I think that when we step into the hygiene room or wherever it is that we're doing these exams, and the patient starts, yeah, oh yeah, yeah, they'll give us the approving nod, right? Yeah, and the intentions behind that may be shallow, right? And I think that there's usually a disconnect that we just take that approving nod as like, oh yeah, we nailed this. Think we got it. Yeah, they're gonna schedule today to come in tomorrow or whatever. And then what do? You go and check and you're like, where did I just talked to Mrs. Smith about replacing that bridge? Did she schedule? And then you go and find out the front desk is like, no, no, she didn't even reschedule for hygiene, and it's like, well, what happened? Where's the disconnect?
Yeah, this is why dentists, I think, overestimate their case acceptance. So in that example of your friend who maybe he's the owner of that shop, maybe he's a technician. That's like who we are. We're the owners, we're the technicians, and often we're trying to sell as well. And I know we hate to use the word sell, but we present the treatment that we think is necessary, um and we're talking to the patient, and the patient's saying, yeah, but you're saying that when you were in there, Dan, your internal dialogue as a consumer, as a customer, was going through all sorts of series of questions. How are those questions similar to the questions our patients are having as we're talking to them about this case, the 6 through 11 veneer case that would not only provide beautiful cosmetic, aesthetic results, but it's also going to provide functional results. It's going to provide strength. It's going to do all these things that we're so sure that we're just killing it and selling this case to this patient. What is this patient thinking?
Yeah, there's an internal negotiation that occurs that isn't it's not verbalized, right? Like I had it going on in when I was looking at that bike because I was like, geez, I've only looked at two bikes, and there's a lot more I need to look at. And do I want to buy used? Do I want to buy new? How much do I want to spend? All this stuff, and that's a normal consumer internal dialogue that occurs. And so, you know, it's healthcare and it's way more important than a mountain bike, but that same dialogue is going to occur within a patient's head. And they're going to be like, well, what are my alternatives? How much is this going to cost me? How much will insurance cover? And then on our end, we have to look and go, how insurance driven is this patient? Did we convey how important this is? Are we backed up by the hygienist or the assistant? Do we have imaging? Do we have photographs to back up what we're talking about? Did we take the necessary steps to really convey what is happening so that that patient has the information? So, yeah, I mean, I think it's interesting because again, it's a consumer's mentality. And when you and I talk a lot about how there's the different kind of consumers too, like I said, if you have the insurance driven consumer versus the cash versus maybe you have a patient benefit plan in your office, there's these different spectrums of patients and what they're going to go through. Some may be on a very strict budget, some might be just be it of the insurance mindset. Oh, heaven help you if you have those. And these are
We have
all
plenty of those.
barriers.
We've got plenty of those mindsets in
Too
our practice.
many, too many of them. But yeah, I mean, I think from our side of all of this is we have to recognize that that is something that's occurring. And the other side of it is that we've got to be able to be vulnerably honest with our numbers. Like we have to be able to say, oh my gosh, we suck at this. But before that, even you have to be able to go, where do I get that information? I bet you someone listening to this has no clue where to find that. Like I wouldn't have like, and I'm not saying that like I'm not being rude. I'm just being like, I wouldn't if I had EagleSoft or Open Dental or whatever the heck, how are you going to find that? You know what I mean? Like, and again, I go back and I love to pick on my on these poor docs that refuse to use any type of data analytics. And this is a fun one to bring up. And I always put a bet on the line, like pay $100 right now if you can call your office manager and get this information in the next, hour. Nobody can do it. And if they don't have a data analytics component in their practice, they can't do it. And I'm like, again, I'm being a jerk about it, but the point is you got to have something to be able to go and find this, right?
Yeah, no, you have to be able to have some sort of, I don't even going trying to pull this data from manually from your operating system is it's an exercise in futility. It would take forever, and then to try to understand it and put it together is so hard. And we use Dental Intel. There's other ones, practice by numbers, whatever your data software system is. Make sure you have it. Make sure that it's pulling the data correctly. So first of all, you have to know where to find the data. If you have a dashboard from your dental your data analytics software like Dental Intel, it will have it on maybe the front page. Or if not, you can go into the bar on the left hand side and you can find case acceptance percentage. And then you need to here's what's really, really cool about case acceptance percentage is you can divide it up into provider. So if you have more than one doctor, like you and I, we practice it in the same practice. We're 50 partners. And we go through and we can say, okay, last week, how was my case acceptance percentage versus how was Dr. Nelson's case acceptance percentage? And not only that, you can divide it in further. So it will give you the data in treatment teams. So if I go and do exams in Shayla's room, one of our hygienists, then it will say treatment teams, Shayla and Dr. Hill, and it will give us our treatment acceptance percentage based upon what was diagnosed and what was scheduled out of that exam, out of that day, out of that exam. So a couple things you need to know about this data and this metric is it doesn't take into consideration necessarily your previous treatment. That goes under a different part of the case acceptance. What we're trying to see is we're trying to see when you have an exam, whether it be an emergency patient or a hygiene patient or maybe a consultation, what was presented that day and what was accepted that day. So this is your case acceptance percentage.
So
And
same day treatment acceptance, not previous. So if it's novel or new into the treatment plan that day, that's what it's tracking.
right, and that's a value in and of itself. Your treatment coordinator, your office manager should be looking at previous treatment and presenting maybe some previous treatment. But what is diagnosis? And maybe what happens too is there's so many things that go into this, Dan, that like I've learned so many things over the years as far as um, if there's something that's been diagnosed for a year or 2 or 3 years and hasn't been done, you need to update that. So you're going to change your fee schedule and you need to update that into your operating system, EagleSoft or Dentrix or Open Dental, whatever it is. Update that because you're going to update the fee. Otherwise, you're going to have an old fee presentation, and that's not going to do you any good. So you have this new fee, your updated fee, and then that then counts as represented or re-diagnosed that day, and that will go into your case acceptance. Maybe we're going a little too deep into this, but there's so much that goes into this. It's very interesting to understand what your case acceptance is. Back to my original point, maybe I'm really good with one of my hygienists. Maybe Shayla and I, maybe every time I go in a room with Shayla, my case acceptance is 70%, 80%, 90%. But maybe when I go in with Danielle, who's one of our newer hygienists, my case acceptance is 20%, 15%. And I don't know unless I'm looking at that. All I'm doing as a dentist, I'm going into Danielle's room. I'm saying, hey, Mrs. Jones, and we really need to get these two crowns done on 3 and 4. You have these old silver fillings, fractured lines, whatever it may be. And she's giving me the nod, right? Yeah, yeah. And then I walk out of the room thinking, great, I'm going to see her on my schedule in sometime in the next couple of weeks. And then what happens? Then you go on with the rest of your day. And then 6 months comes around and I see Mrs. Jones again. If I'm not tracking this, I'm see Ms. Jones again. I say, oh man, didn't we talk last time about these two crowns that we needed to do 6 months ago? Oh yeah, I was gonna check my insurance and whatever. But they never got scheduled. But I'm not seeing that unless I'm checking my case acceptance. Whereas if I'm checking my case acceptance, next Monday, I'm looking at my case acceptance with my hygiene team and I say, oh man, Danielle, we only had a 15% case acceptance rate. What happened? Let's dive into it. We click on it, we dive into it. It will tell you, it will bring up all of the patients that you saw. It will tell you what you diagnosed out of that room and whether it got scheduled or not. And I can say, Danielle, we had this great conversation with Mrs. Jones about scheduling 3 and 4 crowns. What happened? Why did those not get scheduled? Oh, well, I just when I took her to the front desk, they were going to check her insurance. And I said, well, she didn't schedule. Let's follow up with that. And there may be a legitimate reason why they didn't schedule, or maybe not. So that this is a powerful metric for you to follow up, an easy one for you to follow up if you know how, one, where to find it, and two, how to use it. And then those things will increase your case acceptance rate. It'll increase your production. It'll increase your collections. Like you said, that it'll cut off that silent leak. It's a huge boost to your revenue if you're taking the time to slow down, check it. That gives you time to then speed up.
Totally. Yeah. And you bring up some, I love that you talked about the teams because you might, like you said, once you can identify those, you can now start to deconstruct what is going wrong, right? Is it a break somewhere that's the problem with the handoff between where the hygiene doc team is really good, but then the handoff to the front desk sucks and something's not happening there? Or is it something that we're saying or somebody else is saying, or are they just not putting it in? What is it? And I love that ability to look at it and go, okay, we see some variability between the hygienist. The doc is consistent, but the hygienists are variable. Or the hygienist can come back and be like, no, no, they said they were going to schedule when I handed it off to the front desk. And then you can go to the front desk and be like, what happened? Why is this falling apart? And I think that leads us into kind of what we were discussing a little bit a minute ago, and I think we need to really talk about some of the three biggest barriers to case acceptance. So now we're looking at it and we can see, well, before that, Jared, we were talking earlier. Why don't you hit on some of the metrics that you were talking to me and Ryan about on the averages? So just let's lay it out. Like, what are the actual numbers of what are the benchmarks for case acceptance?
Yeah, I was thinking that I don't know that we ever actually hit that. We talked about what people thought it is, and they probably estimate that they're in the high 70s or 80s or so. But what is it actually? The average case acceptance rate across the nation is actually only 42%. That's less than half. It's crazy. And then the bottom 10% of performers are like at a 26% acceptance rate. If you're a top performer, you're at a 61% case acceptance rate. And what's interesting, if you are sitting at about 80 or 90 or 100% case acceptance rate, that means you're not diagnosing enough. That means that you're diagnosing a little filling here and there. You're catering to maybe the patient's insurance needs or wants or desires. You're not being as comprehensive enough. You should be somewhere around 60%. And that means you're diagnosing enough to where you're presenting a lot, but maybe the case acceptance isn't quite as high because you're presenting maybe these big dollar cases or more comprehensive cases or whatever it may be. But you shouldn't be in the 26% or even less than that. You shouldn't be in the 42%. You should really shoot for somewhere around the 65% treatment acceptance case percent.
So before we get into the barriers, I do want to touch on what can muddy up those numbers really fast.
Oh yeah. This is
And
clean data versus dirty data.
yeah, yeah, we see
Yeah.
this in our own practice because I think every practice is going to see what I'm about to talk about just because it's part of the nature of the beast, and that's multiple treatment plan options, right? So if I got a patient that comes in and they're missing number, 13, and now I've given them the option to do an implant on 13, or I've given them an option to do a bridge from 12 to 14, or maybe whatever your doing at your office, that you've given these multiple options. Now the treatment plan numbers that went into their treatment plan are big, but if they only take, well, like I'm going to do the bridge, but nobody bothers to remove the implant option, that's in there forever. And that's going to do two things. One, it's going to ruin your case acceptance rate because of course they're not going to choose a bridge and an implant. Like that doesn't make any sense. So if you haven't trained your office staff to delete and take out the options once the patient is moving forward with something, that's going to muddy the waters. And then the other thing that it does is it goes into this giant junk drawer of unaccepted treatment that when we run a growth report, if we run some of the analytics that we do on our end for our clients and our docs, uh, we start looking at that and go, you have a crap ton of unaccepted treatment. And then we go and look in it. It's like, yeah, because I've given them 8 options on these things and nobody bothered to take them out. They've already done the one thing, but it's still in there. So that just muddies the water really quick, makes it hard to get clean data.
There's one other thing I want to add to that, Dan, is when you schedule them, when you put them in the schedule, a couple weeks out or whatever month out or whatever it is, you have to attach the code of
Mm.
of the service that you're going to be doing. So if you say, "Oh, yeah, Mrs. Jones, she's scheduled out in 4 months," well, you may have reserved the time for her, but if you didn't attach the code, it's not going to come up as accepted treatment. So you have to. This is one issue that we had in our practice when we first started to track data is we didn't attach all the right codes, or sometimes we wouldn't even have a code associated with with the time scheduled for the treatment. Right? And so you go back and say, oh, my case acceptance is 10%. Well, no, maybe it's more, but you need to be able to be clean with your data, organized, and it takes a few weeks really just to sit down and figure out um, why it's tracking wrong or whatever. And then once you clean up the data, then you can make a clear decision. You don't want to make decisions based off this dirty data, like you're saying, like these extra treatments that aren't rejected or deleted, or these um, appointments that are made without codes that are attached to them because they're not going to give you the right data. So it's that's an important thing when you look at this metric specifically are those things that Dan and I just talked about.
That's a good point. We could do a friggin' episode. We should do an episode just on coding,
Yeah.
just the
Oh my
correct
gosh.
code. Real quick, just a
Yeah.
shout out to Practice Booster. We use Practice Booster. I don't even think they know we exist, so we don't get any
Probably not.
kickbacks or anything.
No.
But it is a cool. We like Practice Booster, so get on top of your coding. But yeah, dude, that would be a good episode. I think people would be interested in hearing how things are miscoded and learning what global fees are and how we're getting screwed over by insurance with that kind of stuff and how to some workarounds. Anyway, so let's get into the three biggest barriers of case acceptance. So uh, I think that we should kick off with trust. Um, you and I both served missions, and you went to Argentina. I was in Iowa. And one of the first things that they teach you is that you need to build a relationship of trust. You need to be honest with people. You need to be sincere, and you need to be working in earnest, right? And I think that holds super true. Dentists are still fairly trusted. We've dropped down in the past 10, 15 years. I remember seeing that data sheet pulled up in dental school, how we're slipping we used to be number one. We used to be the number one most trusted profession, and now we're like fifth or sixth. I don't remember what it is. But we've certainly slid down. I think we can point the finger at a few things there, but the bottom line is that people will take action more easily when they trust you, right? And boy, any part of your team can break that trust,
Yeah.
depending on what the dialogue is and what's said. Yeah, this
Well, it
this
starts with you as the dentist, right? So
totally.
your body language, your nonverbal cues, all these things is you present treatment, you have to be confident in what you're presenting. But that's only like the tip of the iceberg, like you said. Your office can really make or break that trust as well, because what happens when you leave the room? They turn to the assistant or turn to the hygienist and say, What would you do?
Yep.
And if you don't have the trust of your team, if they're like, well, I might wait and hold off a little bit to see, then that's going to break it. If you don't have these conversations with your hygiene team or your front office, that could be one spot where it's broken. The confidence from your assistant or the confidence from your hygienist. Two, when it goes up front and your front office is like, well, we're booked out for a long time, or your insurance probably isn't going to cover it, or these negative first statements that come from maybe some people, just reactionary statements, can really kill your case acceptance. They can really throw things off. So yeah, all those things. So the first barrier I would say would be trust, coming from you, coming from your team, everybody. I think another barrier, maybe the second one, is a clarity barrier. So
Hmm.
we have in our mind awesome jargon, and a lot of times we want to show to the patient how smart we are, with using a lot of this jargon, maybe overwhelming a little bit, but in reality, all it does is confuse them. And so it too much jargon, too much, using periodontal ligaments, attachments, or acronyms, the PDLs, these periapical abscess, PAA, whatever. It's gonna make the value proposition decrease. It's gonna be unclear, and when I'm unclear about what I'm buying, spending my money on, I hesitate big time about that. They patients don't accept what they don't understand. And I think that's a big barrier, especially to a lot of people when they're first coming out of school, is using big words and dental technical terms is not impressive. It's
I,
what's impressive is using visuals, using analogies, why now, the value proposition of why I need to do it now. These things are incredibly important for a patient to accept the treatment that you're presenting.
so yeah, I like to think about when our friend Jake Rushton, 401k Jake came. He didn't even know, like we gave him that nickname. He's like, why do people call me 401k Jake? I was like, dude, you got it everywhere. Like, and like you shouldn't be surprised. But anyway, so Jake comes and talks to us about 401k stuff, right? And he's talking and he's confident in what he's talking about, and you can see he's passionate about it. He's an expert on it. He got done and I was like, Jake, can you just start over and talk to me like I'm in kindergarten, because I don't know anything that you just said. Like,
Yeah.
he talked for a half hour and I was like, I don't, is there a coloring book that goes with this? Is there like something that will help me to understand? Because I had no idea. And it was a really good moment, really good reminder of like, that's how our patients feel when we start just word vomiting all over them about everything, because it's a different language. It's a completely different language. And to get caught up in that, and the other time that I saw that was we had an associate that she was a very gifted, she's a wonderfully talented doc clinician, but when she was brand new, and you get so caught up and used to using those words in our daily practice, and so she would talk to the patients, but she would use these insider jargon and these, all of these clinical, large, big clinical words and stuff. And the poor patient had no idea. And I remember pulling her aside and said, yeah, they don't know what you just said. Like, they have no idea what you just said. I said, go. And on the flip side, Jared is extremely skilled at simplifying and making clear what he's talking about, making it easy for the patients to know what he's talking about.
That's
Um,
just how my mind works. I can't think complicated thoughts. I can't put together a full sentence of heavy duty dental words. So I connect well with the simple person.
yeah, I'd still follow my principle of why use 20 words when you can use 2000. I think that is, I just try to overwhelm them with many words, and drawings and lots of hand gestures and stuff.
Yeah.
It's by the end, they're just whatever, just leave. I'll do whatever you say. I'll do it. Just go away.
So
Uh,
so clarity is definitely probably the second one. I think the last one is an obvious one. I think this is probably where our mind goes first, is affordability,
yeah,
like the cost of the treatment. And this is,
totally.
it doesn't matter. I mean, every patient, I don't care how much money you have, you obviously think about the cost, and then also the pain, is it going to hurt? So
Oh yeah. Hey, you just stole. I was going to ask you, what do you think? Because I don't know if you saw this or not. What do you think patients are more adverse to, pain or money, spending money?
I think it's probably spending money. I
It's
don't know.
spending money.
Is
Yeah.
it? Yeah, that's what I would guess. Both of them are on their minds, but when it hits the pocketbook,
It's more
if
painful to hit the wallet than it is the shot in the mouth.
I feel like if it's a free extraction, there, it hurts less than if it's a costly extraction.
It's
So
less painful. This
yeah,
one doesn't hurt as much.
doesn't hurt as much as right. So offering flexible solutions, membership plans, phased care, maybe financing, um, and then also when you're presenting, is make sure to present the value, not just the cost of what it is. So you're not
Yeah.
apologetic about the price. I was,
So,
you know, if you want to, experience this, we have our front office, Sandra. I was up the other day. We're not in the front office very much, but I was up getting a script to write, and she was collecting treatment or collecting money from the patient, and she was like, "Oh, today's portion is going to be $3,462," and the patient's like, "What?" Like, even though she'd been clearly explained to, and had agreed to the price beforehand, every patient always gives a little what, and Sandra's like, yep, $3,342, and like that's it, like bug-eyed, like that's what it is. This is the value, and they're like, yeah, okay, all right, well, here's how I pay for it, but not apologetic about it. It costs you a lot of money to go to school, to buy a practice. You come out, you're a couple $1 million in debt probably at this point in time. You have a $10,000, $12,000 monthly pay. You've got an office to run, you've got a building to pay for, you've got overhead. Like, it's dentistry is not cheap. It's not cheap to get into it. It's not cheap to provide it. Don't be apologetic about it. Like, you set your fees, you set your prices, you do it strategically. You don't be out of the realm of normal or average or whatever you want to be, 60, 70, 80th percentile, but don't be apologetic for it. Those are important.
yeah, I think that that's one of the biggest things that is a tripping point for docs. I don't know where that mentality comes from. I think it's just getting beat down from patients over time, but I've seen new docs do it too, where um yeah, this whole like I just feel bad for charging. I just feel like I feel good. Why? Why? When you go and get a surgery on your knee done, do they like or if you go to a restaurant and you order something, do you think that they feel bad? Like, yeah, I feel bad. Like you look really hungry, so I discounted it. It's like we as dentists, because we own the practices, sometimes feel beholden to these patients to offer them some kind of, I don't know, discount or that we need to somehow lessen the impact of what we're doing. And the reality is that we are providing an amazing service that nobody else can do, by the way, and that you didn't put that cavity there. You didn't tell them to chew on that ice. Like these are not things like you didn't go in there with a hammer and just start breaking teeth, and start shoving Skittles into their mouth. So but somehow we feel like, oh man, this is my responsibility. It is not. That is a horrible mentality to get to. And if you have that mentality, the patients feel that, and boy, it's blood in the water for a shark. They were gonna sense it. They're gonna and they're gonna start to pick up on this unnecessary empathy towards the bill. And they're not gonna if you don't value what you do, they're not gonna value what you do.
Yeah,
So
it's going to decrease your case acceptance. Like,
totally, it's
if
gonna
you're
100%.
apologetic, if you're not sure about what you're charging, or why you're charging that much, they're going to be like, I don't know if this is value, if it's that value. If the doctor is hesitating on how much he's charging for it, like, it's can't be that valuable. I'm gonna really think about whether I should do this or not. So that's going to definitely negatively increase your case acceptance percentage.
So we touched on some of the barriers. We kind of hit on definitely tracking the information and knowing how to go and find it, cleaning up your data, make sure your data is clean so you can look at good data. Once we start doing all that, Jared, what's the next steps? Like, what do you think we need to have? people doing in order to increase their case acceptance. Once they're tracking it, they've recognized like, man, I suck at presenting treatment. I need to change something, or I'm freaking awesome at this. Or I have some weak spots in the handoff. We need to better do what? What's next?
So you touched on it briefly. Simply start. You just got to start. You just got to start. You got to start tracking it. You have to um, have whatever analytics software you have, and you need to know where to find it. First of all, as an owner, as a business owner, that's your responsibility to know where to find that data on Dental Intel. It's for us, we use that. We use Dental Intel. It's on our dashboard, and we know that we can click on it and we can look at it. Two, make sure that your data is correct, meaning make sure it's been inputted correctly, make sure you've had this conversation with your team, make sure everybody's on board. And then once you have all that information, the data, and once you're able to find it and track it, then you need to be able to assess it. Meaning, now what is that data telling you? What information can you gather from those numbers that show up on a screen? So you have to review it. We review ours weekly as a team. I sit down with a hygienist personally and I review all of it because most of it is hygienist and treatment coordinator. Some of
Mhm.
it's going to come out of your operatory from an emergency visit, whatever. But the majority of your treatment plan, your case acceptance, probably coming from your hygiene department or from your treatment coordinator. So weekly review of that. Okay, and then what you should be doing then is you're picking one provider and then one procedure to focus on. So if you've got an outlier, hey, we've got in 10% cases in Danielle's row, but we have 90% case acceptance or 60% case acceptance in Shayla's row. Shayla, what are we doing in your room? Can we walk through this? When I walk into your room, what are you doing to prepare for
Yeah.
me walking in so Danielle can see and hear what's going on? What is the verbiage that you're doing? So it's almost like you're role playing, saying, okay, when I walk into a room, when I walk into Shayla's room, Shayla says, these x-rays are new today, Dr. Hill. We've been keeping an eye on number 3. It's not bothering her, but it looks like the crack is getting a little bit bigger. Mrs. Jones is really wanting to be proactive and take care of this before it breaks. Do you think it's a good time to do this? And I walk in, I diagnose, and Danielle's like, oh, okay. So this is the setup we need to be having before the doctor comes in. This is the most successful way for us to increase our case acceptance is by using this consistent dialogue throughout. So that needs to happen is that review weekly as a team in order to be able to know where you're at. And then you need to be implementing the changes. So after you have that review with whatever hygienist or your treatment coordinator, the next week you're reviewing that, and then you're setting and then you need to set your goals. So what is your case acceptance percentage now? If it's in the 40%, increase it to 50%. If it's in the 50s, increase it to 60. But look for a healthy range of where you should be at. If you want to talk with us, we're happy to share all of our data and information. You can hop on our community at school and ask some questions regarding case acceptance. Everybody's willing to share what they're willing to share, but
School with a K.
school with a K. It's
Well,
because
I think too, Jared, and I was, as you're talking, I'm just going through my head on things that we've learned over the years on top of all this. And typically we don't talk a lot about like do this clinically or do that clinically, but I will say that if you want to have your treatment acceptance rate go up, um, what's that quote? Don't tell someone something you can show them.
yeah,
Um,
it's fantastic.
do two things. First of all, get an intraoral camera. Like get an intraoral camera. The
Yeah.
intraoral camera is a game changer for treatment acceptance because if you can show them how their tooth looks like Swiss cheese and that there's a giant, huge cavity there, or there's a chunk of tooth missing, or there's, it's barely hanging on, it's going to crack in 4 places, fracture in 4 places, whatever it is, let them see it. Let them see what's happening rather than you sitting there for 5 minutes trying to explain and describe what's going on in their mouth. Show them, pictures worth 1,000 words. The second thing on top of that is that if you have cases that you've done in the past that you can show somebody, whether it be an implant, whether it be cosmetic, whether it be the before and after of just a posterior crown showing someone like the stability and the strength now that has where it was a very vulnerable tooth before, or X-ray showing whatever it is, anything you can show them to show your craft and your skill and what is capable through your office. Show them bleaching cases, whatever it is. Like, have a book. I always like Dr. Drew's book, that he had of all of the cases that he did, that patients in the waiting room would just flip through. I thought that was a brilliant thing. So these are a couple of things that if you want to improve your treatment acceptance outside of the conversation, these are a couple things that are no-brainers that can help.
Yeah. And to kind of exactly, it make sure it's a good quality intraoral camera. We got the $30 ones that came in a cereal box once, and those weren't very good.
The
Those
Cracker
did
Jack one,
Cracker Jack ones did not. I mean, those are a waste of money, the waste of $30, no, whatever it was. But um,
three hundred
I
dollars.
probably wouldn't. I'm sure I paid a lot more for that. I wouldn't have paid more than that. But
Yeah,
uh,
it was
un,
300 bucks.
at the end of the day, unlocking revenue doesn't start with more patients. So you don't always have to add more patients. You don't have to be growing. It starts with helping more of your patients that you already have.
Acres of diamonds, baby.
Acres of diamonds is right. Like, be more efficient with what you do and with what you have. And this is a great way to do this. You're tracking this one metric. We're going over all these metrics. There's so many metrics to go over, but there's a reason why this is a KPI. It's a key performance indicator. It's one of the most important metrics you can look at to unlock the revenue of your practice without having to go out and spend a lot of money to capture more patients, right? It allows you to do more of the dentistry that you want to do in the time that you want to do it, and treat the patients the way that you want to treat them, and getting the whole team on board with this. So I love this metric.
Totally. And like Jared was saying, if anybody has questions on this, you don't have to be a member to talk to us. You call us, let us know, shoot us an email. We can help with a lot of these things. We can coach you through, where to find and how to track this efficiently and effectively, so you're not just shooting in the dark. Let us help you out. Let us be a resource for anyone looking to improve their case acceptance, or any KPI for that matter. Check us out, elevationassociation.com. We're also on Instagram, we're on Facebook and all that. Follow us, check it out on those platforms. And we're going to continue this KPI series next time. So be sure to check that podcast out as well. Any parting shots before we wrap up, Jared?
No, we also may sprinkle in a couple other podcasts with some other topics as well, but this is the weekly one. This is for the next little while. This is you can guarantee to hear a weekly podcast on a KPI, but we've got so much information to share and give, and we have so much interest in a lot of different areas of dentistry that we're excited to dive deep into this. So thanks everybody
Even
for
out,
listening.
well, to your point, hey, are you going to interview Jeremiah, your bodybuilding coach? Is that going to
Yeah, I
happen?
mean,
People are interested. People are talking.
as a preview for upcoming stuff, I'm going to be interviewing Jeremiah, who is my bodybuilding coach, who's going to talk a lot about health and fitness, and we'll dive into some of the things that a dentist can do. Listen, I'm some whatever dude, or just like anybody who's listening to this podcast. There's nothing special about me or about my body or physique. I was not blessed with amazing gene, nothing like. I went from zero to on a show on a stage in 8 months, about a year or so. So it can be done. You can turn things around, and I've shared a lot about my journey with that. But it'd be kind of fun to get my coach on and get his perspective of what that was like and how to do that. So
Totally. And geez, Jared, that feels like what you should do? You should use that in a presentation at some point, because it feels like there's a lot of parallels between this and running a practice.
yeah, that would be good, right?
Yeah, I think it would be good personally, but you know,
Well,
I'm no bodybuilder.
Well, it's a lot of sweet lessons, and I don't want to overuse it, but there's so many good parallel lessons that go along with it, and I think it's kind of interesting. So it's
We'll call it the parable of the bodybuilder.
parable of the bodybuilder. I love it.
Awesome. Well, thanks for listening, everybody. Check us out next week. Until then, have a great week, and we'll talk to you then. Cheers.
Cheers.